think this is going to be a really interactive workshop that we all should enjoy and have fun. So I have a co-chair with me, Prof. Estelle Verberg. And just to apologize, I think somewhere on the program her name was spelt incorrectly. If it's still like that, please, apologies for that. Estelle is the head of transplant and clinical hematology at Idrc and UCT. She is a consultant hematologist and has her PhD from Belgium in myelodysplastic syndromes. So I want to welcome her as the chair. She is going to introduce the first session, which I'm really looking forward to. It's unpacking the transplant journey. So Estelle will introduce our speakers, if they would come up, and then once you've spoken, please just stay on the stage, grab a seat down here, and we'll move into the panel discussion from there. Just a few rules. Please make sure your cell phones are switched off, number one. Number two, we are going to be trying to keep strictly to time, so you will see your time flashing as you talk, and it will give you your time, it will let you know when you have to stop, and it will give you a 5-minute warning. It will be right here on the screen in front of you. So we'll try and keep strictly to times. We do have some time for panel discussion as well in this first session, so I'm really looking forward to that. I'm going to ask Estelle just to introduce our two speakers.
So a very warm welcome to everybody to Cape Town, together with Charlotte. Pierre, and there's an old mentor from Belgium here. So it's great to see you, Pierre. Is Marie-Paul here too? Oh, okay. So it was actually my topic, Pierre. I wanted to just say it's so wonderful to see old friends back. We are very, very thankful that we've been spared and that we can gather together. It's not nothing. We work with patients who are very sick every day, and very, very thankful to be here in this place together. And this workshop is going to be great fun, and let's please move nearer when you come in so that we can actually really interact with each other. I just wanted to mention that at the end of the session, then Dr. Andrew MacDonald, who's sitting here in front of me, is also going to come up to be part of the panel. So I'm not going to give a big bio on you, Andrew, but as you told me, at this stage, together with Justin's practice, you are working on NK T-cell trials and your first CAR-T study in South Africa. So that is amazing and enormous work that's been done in those practices. So so that's my introduction to Andrew. Great transplanter in South Africa. And now let's get to Bronwyn, our honorary South African, our real one, but the one that we're very proud of. It's great to see you here, Bronwyn. So, your academic credentials stretch so far that I'm not going to brag about them, all of them, but you are the Chief Scientific Director of the CIBMTR at the Medical College of Wisconsin. And you are an adult BMT physician, and you are involved in systems and research and setting platforms. So, there you've done an amazing work. So I see you didn't put in all your articles and all the numericals, but we know what you have done. And, the best donor for the patient, that's why we are here today, and that's the work that you've been doing. And then I think we're living in an era where the donor's experience is becoming more important, and then the survivorship and the quality of life of the patient. So these are very important things. And then the great thing of actually harmonizing things, working together. So that's what your field is. And we welcome you. And your title today is A Brief History and Emerging Concepts of Transplantation. So you're going to come up right now, but I'm going to quickly introduce Justin too. So, Justin, you are what will we do in South Africa without you in stem cell transplantation? So that's how I feel. I don't know what we would do without you. We're thankful that you are part of the new generation of transplanters that is really building transplant as a platform in this country. So you have lots of academic credentials too. You've done your master's in science in Rotterdam, where you still keep up enormously good relationships with your mentors there, and is busy pursuing a PhD, working with them and working with us in South Africa. And then you are establishing together with Jackie, the Wits Donald Gordon Cellular and Immunotherapy Center. Did you do it on purpose, CIC? It's like an EBMT center. So CIC has got a CIC number with EBMT. And so there you've been settling transplants and doing amazing work. And can I just congratulate you on being with Jackie, on being the third center in South Africa with JC accreditation. So the second, sorry. So just awarded, so really, you really move and shake in the area of stem cell transplantation. So you also love teaching and educating, so that's what you will do today. And your topic today will be very apt: transplant strategies in low and middle income countries, the South African experience. Thank you, Bronwyn.
Good morning, everybody. It's so exciting to be here. Very nice to be in Cape Town, where I was at medical school. I think most of you know that, so kind of my old stomping ground. Thank you to Charlotte and Jane and Janine and everybody else who's put on a really, truly amazing conference and been so well organized, so we really appreciate that. And thank you, Estelle. So I think this is going to be a really nice session, and I'm looking forward to sparring a bit with Justin, maybe, if we've got some time during the questions. Okay, so I hope I don't just have 7 minutes for my talk. So, we'll see. All right. So when we were discussing this session ahead of time, I think that what we really wanted to do is put some contrasts into this talk, look at a little bit of history, because I get to be the old one speaking in this session. And then, and I'm not going to dwell on the history long, because I think many of the people in this room really know some of the history, but just bring out some core concepts, and then really talk about what is happening in the US environment and in some other parts of the world where what has become really the standard of care. And finally, to end with some discussion about what the questions are that are facing us as a field at the moment, and hopefully those are the things that will really end up having some lively discussion. So firstly, to start, I think that what we know about this field, transplantation, and Estelle just mentioned some of this, especially with accreditation and with the importance of working together, is that we as a community, WMDA is a perfect example, have really collaborated, which has helped us to get to where we want. But everything we've done has been based on science and the curiosity and the need to learn. So this is going to be my oldest slide. This is a slide that shows one of the very first papers in the field from 1970 from the person who started the CIBMTR, or the IBMTR as it was then. And, this slide showed that in the late 60s, there was this real, or 50s, 60s interest in transplantation. You see those numbers all the way up to 60, wow. And then everybody died of graft versus host disease or graft rejection. It was really not a time that was, full of good outcomes. And so there was this question about what is going to happen next. And I'm not going to leave you in suspense, of course, because everybody in this room knows what happened next. These are the data from the CIBMTR, and showing you that transplantation really took off. Of course, this is autologous and allogeneic transplant shown on here, and then you see the little blue at the top there with the new CAR T cells mostly, but other cellular therapies being reported to the registry. So, you know, how did this happen? How did we get so far ahead? Like I said, I think a lot of this was research. If you look way back, even in the 90s, you know, the outcomes for transplant were very, very different depending on which sort of donor you had. So if you had an HLA identical sibling, which even today many people would argue in most circumstances is probably the best donor, you can see that the survival was way better than if you had any other type of donor, including a matched unrelated, mismatched unrelated, a haploidentical donor. And even if you bring that forward by another 10 years, you can see that there were great differences in these different transplant outcomes based on the donor, although of course you can see that over time, outcomes are improving across the board. So some of the really, really important things to do I'm going to bring out in the next couple of slides. So one of them is graft versus host disease prophylaxis. So we know that when transplants first happened, the type of HLA typing that was done, even with siblings, wasn't like we expect today. There was a lot of graft versus host disease, a lot of alloreactivity between the patients and donors, and you really needed something efficient to try and combat that. And so some of these early strategies to reduce GVHD became the standard of care. You see there on the left-hand side the clinical trial that looked at calcineurin inhibitors compared to methotrexate and calcineurin inhibitors, showing the difference in GVHD incidence, and so that really became the standard of care for transplantation. At the same on the other hand, we also know that there are T-cell depletion methods. So this is an example from Steve and colleagues in the US that was looking at CD34 enriched cells, so T-cell depletion in the actual graft. I'm not going to spend too much time on this because Justin's really going to take this concept forward, and I'm going to just touch on PT-Sci later in my talk. So what was the other thing that happened was really this explosion of our knowledge about HLA disparity and the importance of HLA in transplantation. This is a slide that I got from Steve Marsh from the WHO Nomenclature Committee. You can see that there's just been this continued massive growth of new alleles that have been named, you know, both at HLA class 1 and 2, starting just, you know, with serology and now really at high resolution, ultra high resolution, third generation sequencing techniques. And the only way we could do this was as a community, and really the fact that huge transplant registries around the world contribute all their data together has really allowed us to understand this well. And in this room, you know, many, many people here have contributed to the amazing work that WMDA has done to make sure that everybody can be connected all over the world to find these donors and then to provide the donors to somebody wherever they are. And you see this lovely side with that huge growth in unrelated donors, really now, you know, in the millions of donors available all over the world. And one of the things that we've tried to do in the CIBMTR, and I'm going to show this quite a lot through the talk, is to prepare a set of summary slides annually, which essentially show trends in transplantation. What are we doing? What are the new things? What are the things that become practice quickly? And this is something that really is nice to see. This is a credit to the entire community, that if you look at these 3 different eras, starting back in 2001, and then the most recent one through 2021, where you see that improvement in overall survival in each of these eras, which, you know, is why we can be proud of ourselves, but we can also see that that overall survival is maybe not where we would really like it to be, and so more work to be done. So we, as I mentioned, we wanted to put this really into some context of what are the common practices and things that we maybe think of as standard of care in the USA, and then how that's really going to differ in a country such as South Africa and other parts of Africa where transplantation is really at its very infancy. And I'm just going to go over some of these very quickly, not to get into the details too much. These, many of these are the summary slides from the CIBMTR, and by the way, these are all freely available on the website if people do want to use them. But so you won't be surprised to see some of the activity here, what the most common diseases are that are being transplanted in the US. You know, in the blue there, you see the autologous transplant, so myeloma, some of the lymphomas, you know, really growing in transplant. But AML, acute myeloid leukemia, and myelodysplasia really being the most common diseases for allogeneic transplants. In the world of cellular immunotherapy we're in at the moment, though, we can see that practice has been changing quite a lot for the last few years. So hearing about your first CAR-T study coming along, you know, in the US, there are several CAR-T cells that have already been approved, and so this has become standard of care, and CIBMTR is collecting data in these. And here you can see what's really interesting in the lymphoma space is that you see that number of allogeneic transplants in the plum color sort of going down a little bit, but what you really see is autologous transplants in the blue, in the dark blue, going down over time as these CAR T cell therapies become more available. And what we also see is a difference in whether people have had a transplant before they come to CAR T. Initially that was the case, and now that's really changing. In pediatric transplant, I know there's a bunch of pediatric transplanters in the room. There's a lot of different diseases, obviously, than we have in adults. And here you see a bit more of a mix of hematological diseases, some solid tumors, and other early childhood or inborn issues. So what about the type of thing that we think about all the time when we're transplanting in terms of selecting patients, thinking about who's eligible to have a transplant? What you can see here is, at least in the US, we're transplanting a much older population. The yellow at the top, just that tiny little slither, is over 75. It's the first time we put the over 75s on these slides, and you can see that's growing. But really, if you look at that gray bar, the over 65, that's really where the growth is here. So, you know, we have to do transplants in a little bit of a different way when we're thinking about patients of older age and also sicker patients. You know, the HCTCI, the comorbidity index, which gives patients a score before their transplant to predict their non-relapse mortality. And you can see here that, you know, really in the myeloablative transplants, more than 10%, and in the reduced intensity, more than 20%, have an HCTCI over, you know, 5, which is a lot of comorbidities, really. But these are all transplants that can be done, you know, and we look at those survivals that are improving. So you think about an older age group and you think of higher comorbidities, and yet transplant outcomes continue to improve across the board. Just because I know we're going to talk about this, just very briefly looking at some of the common regimens that are used in the US for myeloablative and reduced intensity. You know, really, TBI is much less commonly used for acute myeloid leukemia, and so you see these are combinations really of a lot of busulfan and fludarabine in general. And then also in ALL, you see that TBI obviously here is still more commonly used in these transplant settings. Now, what about when we think about some of the practices of doing the transplant? Well, as you can tell here, this is a 10-year period of the data in the US. This is very similar to data in other countries and in the EBMT, showing that peripheral blood stem cells are really the standard of care graft source for adult transplantation. That's the big plum color there. You see that bone marrow has, you know, maintained a position in being used, particularly in certain diseases. For example, aplastic anemia in adults even, we know that bone marrow is commonly used. And then you see a little bit of cord blood use. Of course, this is very different in the pediatric environment, where bone marrow is still the predominant use, but you can see over time that there's been a little bit of fluctuation, and there's certainly quite a chunk of transplants done with PBSC, and in many cases this is because of graft manipulation strategies, getting the graft and doing different things to it. Again, going to leave this all to Justin to go into detail, but that changes what people have done. So now coming a little bit to more recent, I touched on that graft versus host disease prophylaxis being such a game changer in the early transplant era, where you really needed to get these grafts into patients and then prevent the GVHD. Well, we know that for many years, as we've been doing transplants, we've tried to focus on doing matched transplants, HLA identical sibling, matched unrelated, to try and reduce the amount of disparity. But more and more, we've come to learn that there are different ways that you can do the transplant, which make mismatching across or transplanting across HLA barriers more successful. And I'm going to focus a little bit on post-transplant cyclophosphamide, because this is something that really has become not only something we've studied and had good outcomes in the US on clinical trials, but is now in fact standard of care in several circumstances. And so some of the early research that was done, and then some of our colleagues like Chris Kanakari have continued to look at the mechanisms of how post-transplant cyclophosphamide works. But early on, the strategy was giving PT-Cy after the transplant, so days 3 plus or minus 4, usually days 3 and 4, and this causing a dampening of alloreactivity, but particularly sparing the Treg, so changing the immune environment of the transplant after it was done. And this was really game-changing. Haploidentical transplantation was where this was initially used. We know that not all patients have got an HLA identical sibling, of course, but not everybody has a matched unrelated donor. We know that the outcomes with mismatches were not as good, but having a haplo donor was often something where the donor was available. Children and adults, where you've got a child or a parent. And so there was a big focus on increasing access to transplantation through haplotransplant. And you can see that this was very successful, with that grade 3 to 4 graft versus host disease on some of these early studies being really low, and very acceptable rates overall, and overall survival much better than what had been seen historically. And if you bring that forward to a more modern era, and you look at some of the, in this case, I think pediatric transplant, you see that overall survival really being very acceptable. So this approach, as I say, was very acceptable in this circumstance. And what we asked at that time, and this study is called 15 Mismatched Unrelated Donor, because it was 2015 that we wrote this protocol and had this idea to study. We were lucky that NMDP was willing to fund this study. And essentially what we said is, well, if you can do this across an HLA barrier in a haploidentical setting, why shouldn't you be able to do it across an HLA barrier in an unrelated donor setting? And so for this clinical trial, we allowed patients to have a mismatch with their donor that was between 4 and 7 out of 8, so really very mismatched, all the way down to a haplo mismatch. And again, what you can see here is that this was also a very promising approach to use. If you look at the left, in particular the green lines, that's the reduced intensity, which was exactly the same protocol that was being used in those haplotransplants that I showed on the previous slide. And you can see that there was actually no patients who had grade 3 to 4 graft versus host disease at all in that setting. There was a little bit more graft versus host disease in the myeloablative setting, and we could talk about that in the questions. But you can see that that overall survival was very, very acceptable. In fact, the 1-year survival was above what we hypothesized it would be in the clinical trial. And then because all of these patients had also enrolled on the CIBMTR registry, even though the trial was over, we were able to look at the survival 3 years later, and you can see that that survival is still very good, and we weren't seeing a difference in outcome depending on whether they got myeloablative or reduced intensity conditioning. The most recent study, just to complete accrual in the CIBMTR, which our clinical trial platform changed a little bit over the years. We now have a CRO that runs these trials. Luckily, the NMDP has continued to contribute heavily towards these studies in terms of funding. And this study has just completed this early analysis, the first 70 patients. This was presented at the big the big oncology meeting in Chicago recently, which has a small transplant section. But this actually was a prize lecture, best abstract. And the difference in this study was, although this is the first 70, it's a much larger study, included almost 3 times as many patients. It also includes children. The pediatric side is still accruing, and used, importantly, peripheral blood stem cells instead of bone marrow. For that first study, we used bone marrow as the graft source because we weren't sure how the mismatch unrelated platform would really compare to haplo. We wanted to keep the GVHD levels as low as we could. But you know, as I showed you previously, everybody's using PBSC, and so practically this was the logical next step to take. And you can see here an overall survival at 1 year of 79%. So just the same as the bone marrow, really good. And with both of these studies, one of the really important things that we've seen is that about half of the patients receiving these mismatch unrelated donor transplants are patients who are from racial or ethnic minority backgrounds, which in the United States is not the typical norm. Usually we see somewhere, depending on the diseases, but usually something between 70 to 85% of all the transplants patients are white, particularly when you have matched donors. Haplo donors changes this a bit, of course. And also when we enroll on clinical trials, we usually see that there's a much lower percentage of patients who have diverse backgrounds. And so these are data that are very encouraging. And Steve, in his talk tomorrow, is going to really go into these data in a lot more detail. And so, as I mentioned to you, the standard of care in the US has really changed. If you look on the left-hand side, that's haploidentical transplant. And in the green is the post-transplant cyclophosphamide. You can see that for almost 10 years, PT-Cy is what's being used in GVHD prophylaxis. When you look at the mismatch unrelated donor, when we started that study, 2015, you can see there was a tiny proportion of patients in green at the bottom who were getting PT-Cy, but still that big blue chunk was calcineurin inhibitor, so usually tacrolimus in the US. Whereas if you bring that forward to 2022, it's well over 60%, almost 70% of patients who are receiving PT-Cy in this setting. So really becoming the standard of care here. Some of the other things that we really focused on, and I'm just going to talk about these very briefly, in the last few years, was thinking about what are the other things that we can concentrate on when we select a donor, because we really studied HLA for a long time. We got to the point where if you had multiple different donors available, in the matched unrelated donor setting particularly, that then you wanted to see what were the other donor characteristics you could select between. And even now in the mismatched setting, we're starting to become really interested in how those factors are going to come into play. And we don't have an enormous amount of data on that yet, and I'm also not going to show any of that, but you might see some more of that tomorrow. Well, one of the things that we became interested in many years ago was looking at the HLA loci that weren't your classic 8 out of 8 or 10 out of 10 polymorphic HLA. And so one of the things that I'd studied early on with many, many colleagues, and we'd done studies with the CIBMTR and also the International Histocompatibility Working Group, and Katharina Fleischhauer has continued to study this for years. And what we saw is that instead of just looking at whether something was matched at an allele level or not, you could look for this permissive matching or mismatching, which is more of a functional definition. And so when we were still really focused on matching, we were trying to understand, are some matches better than others? And so in this matched setting with calcineurin inhibitors, what we'd found is that mismatching for DP for non-permissive mismatches, there were certain mismatches that you should avoid in order to improve the outcome. So that allowed us to be a bit more precise in how we selected our donor. The other thing that we've done a lot of research on, and this has been done again for many years, one of the very first papers actually, from 2008, and then we built on this over the years. But I think that across the board, all the studies that people have done in the unrelated donor setting show that choosing a younger unrelated donor results in better overall survival than an older donor. Kind of makes sense, doesn't it? Young people are, potentially less beaten up. Their stem cells might do well. We don't know exactly the reason for this, and so there's quite a bit of research going on. But this big study that we did, using a very large CIBMTR data set, basically showed that for every 10 years younger the donor was, the outcome was better. And when we did this study, it showed a linear effect. In other words, every year younger that the donor was associated with better outcome in the patient. And I'll talk about that a little bit in a minute. Since then, we've also looked at the age of the donor in other settings. And so now are also showing that if you look at the haploidentical setting, that the age of the donor is also an important factor. So in some cases, transplant centers that were doing a lot of haplo transplants are now restricting their haplos to a younger haplo donor, maybe having a different selection algorithm in the family because of this and a lot of other data that are coming out. But so I mentioned to you the fact that first donor study we did showed a linear effect. And for many of you in the registries who I see sitting here, the question from transplant centers often comes, well, if you need to get a younger donor, is it better to pick a 18-year-old than a 19-year-old? And if that's the case, what happens if they're an ABO mismatch? Or what happens if the DP is different? How much space do you have to choose of a different age? And so this is a very recent study that we've done. Some colleagues that are developing novel statistical techniques, and that's what they use to model this. And what we were able to find is that if you look at donors between 18 and 30, there's less than 1% difference in the outcome for those donors. And so what we're really recommending now that we can see this is that you shouldn't wait to get a donor who's younger by a few years. In fact, even could be several years if the donor is under 30, to be able to go ahead. And that might give you space to look at other factors that you might be considering in this setting. The data here is all done using calcineurin inhibitors, so we haven't yet studied this in the post-transplant cyclophosphamide setting because we're still accruing the patients there, but that's something we're working on at the moment. And so if you look at the CIBMTR data over this last 10-year period that I've been showing you, and you look at how the transplant practice has changed in terms of donor selection, what you can see there is at the top in the green that unrelated donors, matched unrelated donors in that curve, have continued to grow. And that's a testament not only to the increased success of these transplants, but to this community that's managed to get donors to patients all over the world. You can see that line underneath that, that's the matched HLA identical sibling, the dark blue line, that has been reducing over time. Makes sense, right? Because you've only got that many HLA identical siblings available. But also there's some situations where people might not choose that as the ideal donor. And then you see the haploidentical donors in the plum color that really took off at the beginning of this period with PT-Psi. But in the last few years, we've seen started to come down a little bit, probably because of mismatch unrelated donors in the light blue, really starting to increase with these encouraging results. And the yellow is the cord bloods, which you can see there's been a sort of a steady use of cord blood, but again, reducing in more recent years. So I'm going to, for the last period of the talk, just focus on a few questions that are things that we think are important for us to continue to study and for us as a community to address. So the first one of these is that although PT-Psi was really tested in the mismatch setting at first, this was a large randomized clinical trial done through the Blood and Marrow Clinical Transplant Network, the BMT-CTN in the US, which basically randomized patients to PT-Psi versus the standard of care, standard GVHD prophylaxis. And what you can see in the yellow curve there is that the adjusted graft-versus-host disease-free, relapse-free survival was significantly better for those patients who received post-transplant cyclophosphamide. And that is, this one was done in, in multiple different centers in the US. And so what you can see in the green, this is similar to those slides we saw about PT-Psi use in haplo and mismatch mud, but you see that green starting to increase there. And that slide actually shows you matched related donors, but it's very similar in the matched unrelated donors. So around about a third of transplants now happening with post-transplant cyclophosphamide as the GVHD prophylaxis. So there are a number of different settings where this still needs to be tested. There are questions about age of transplant, and so this is a very active area of research, but as you can see, people have really taken the next steps already. But is post-transplant cyclophosphamide the answer? Is that where we can stop? You know, we're doing really well and this is the end? Obviously, the answer is always no, because we know that there are toxicities related to post-transplant cyclophosphamide. The sort of things that we see are increase in infections, and, you know, Justin's going to talk about Campath and, other T-cell depleting techniques where, which this is what PT-Psi is doing as well, where we see a lot more infection, and so this is something that we really need to understand better. We also see cardiac toxicity, for example, with post-transplant cyclophosphamide, and this was a really interesting study where they said, well, if we're using this big dose of PT-Psi, is that too much? Could we bring the dose down? And so tested 3 different dose levels and actually found that when you reduce the dose down to half of the dose, still over 2 days, you could see not an increase in GVHD, but definitely a decrease in infection, as is shown here. And so lots of studies now interested in testing a lower dose of post-transplant cyclophosphamide, and that is the study that is currently accruing in the CIBMTR, the one that follows after the ACCESS study. It's called Optimize. Again, you'll hear more about that tomorrow. But we also know that there are other drugs that have shown promise in this setting. And so one of these is a drug called abatacept. This is a drug that's now FDA approved in the US for prophylaxis for graft-versus-host disease. And what you can see at the top there is that when you compared that, and that's the blue line, to calcineurin inhibitor methotrexate without abatacept, that the survival was significantly better. So we know it is better in a mismatch unrelated donor setting than just the standard of care of that approach. But if you look at it versus PT-Psy, those outcomes are quite similar. So that's very encouraging. And again, when you look at these CIBMTR summary slides, what you'll see is that there's already quite a lot of use of a beta set starting to happen. This is particularly in children, but you see 15% in yellow of children are now getting this approach. There are other methods. Again, we talked about graft manipulation, but this is just one approach. Orca Bio is pioneering, where they manipulate the graft and give the product in sort of split infusions that are more precise. And again, here you can see really encouraging outcomes using this approach. And so I think what we're understanding in these more recent studies, and some of this that I'm showing you, is that one approach might not be the best approach for everybody, and we might be able to get more precise or more exact about what we want to do. Another really interesting thing that we're trying to understand better, and that is quite a provocative issue in the community at the moment, having said for years and years and years that HLA matching is the most important thing that we need to do, we're now saying that actually HLA mismatching is okay and people do just as well, and actually maybe other things are more important than HLA match. And this is a very recent study that was presented at the EBMT last year. This is from CIBMTR data, and showing you that the younger donors, irrespective of these different match groups, you know, matched unrelated donor, haplo donor, mismatch unrelated donor, do better. And what you see with relapse on the right-hand side there, in that solid bar, that's the HLA identical sibling, a matched sibling donor. And we've seen multiple different studies that have shown this, that relapse is higher. And so people are now also starting to ask the question, well, are there certain circumstances, if you've got a patient with a donor who's 70, 72, should you use that donor, or should you go for a younger unrelated donor? And I think that's a very interesting question, especially to address in the South African environment. The question about how mismatched is okay, you know, we, in this study, as I told you, included all the way down to 4 out of 8. This is the MUD study, and you can see that the outcomes were identical, whether it was a 7 out of 8 match donor or a less than 7 out of 8 match donor. These are very small numbers still, but the ACCESS study that I showed you, that early results are showing something similar here. And what's very interesting is I mentioned to you that HLA-DP, that we said you should avoid non-permissive mismatches in the calcineurin inhibitor setting. Well, this is very interesting. This is actually haplo, but what we're seeing here is that in this setting, it's actually better to pick the non-permissive mismatch. And so we might be turning all of these different selection criteria on their head. Another provocative study that has just been published and was presented at ASH last year, with all of these patients receiving post-transplant cyclophosphamide, showing that there was no difference in survival or in graft versus host disease-free, relapse-free survival, whether patients had a 7 out of 8 match or an 8 out of 8 match. So this is another really interesting thing that we should think about. And in my last 2 slides, I'm just going to briefly show you a study that we completed again through the BMT CTN, where the approach with this study was to say we should look at, everybody should look at their donor choices up front, and then make a decision based on something called a search prognosis score. There's some people in the room who know a lot more about this than me. But this was developed by the NMDP, and essentially all you need is the patient's HLA type, and this will tell you how likely they are to find a matched unrelated donor. In this study, the transplant centers had to agree. If they were very likely to find a matched unrelated donor, you proceeded that way per standard of care. If they were very unlikely, you went immediately to an alternate donor option, which could be whatever the transplant center decided, a haplo, a mismatch unrelated donor, or a cord blood transplant. And we didn't wait for the HLA identical siblings to be typed before this either. Everything happened all at once. And if they were found to have an HLA identical sibling later, then that was, they were excluded from this part of the study. And just one high-level result I'm going to show you from that is that there was no significant difference in the patients who got to transplant, whatever type of donor they were using. So testing, looking at all the donors up front and moving quicker, got everybody there at the same rate. So that's really encouraging, and I think something we as a community, and particularly in the registries, should be trying to promote. So, briefly, I don't need to go through all of these points because I think you've seen that transplant has really changed over the years, and everybody in this room has contributed to dramatic improvements across the board, both from the science point of view, but also from the clinical outcomes. Doing prospective clinical trials is absolutely critical to understand some of these important outcomes and make sure that we're really asking the questions and not just reacting to things that are done. But we also need all these outcome registries so that we can really look at change in practice, we can look at standard of care, we can see how things are adopted, and we absolutely need the donor registries to be a partner in this. And I think that we can have some lively conversation over the next 5 days about different factors of how we choose donors in this new environment and what are the most important factors. So I'll finish there, and thank you for your attention.
So good morning, everyone. So I am Justin du Toit. I'm a hematologist. Bronwyn, thank you for that amazing talk. So I'm just going to focus on the South African experience, or rather transplant strategies in our country. I must say it's a great honor to be here, and I'm very grateful. Right, so transplantation in South Africa started in the 1970s, and that was by this Professor Peter Jacobs. You can see him in the right bottom corner. And he's standing there with Trevor Manuel, and this was at Constantiaberg Hospital, which was a private hospital at that time. And he started doing experiments in the 1970s with rabbits, so obviously animal models. And he showed that you can actually, with radiation-induced aplasia in the rabbits, they reconstitute they engraft with bone marrow blocks. Then the next step was getting a cell separator for South Africa. This all started at Groote Hospital, and that's where they pioneered the use of apheresis technology, and that replaced the obsolete delivery of blood products in bottles at that point in time. You wouldn't believe it, it was Horlicks milk bottles. And then, of course, platelets were supplied as a single unit, but without any quality control, so the cell separator actually allowed them to do quality checks on the platelets. And this finally permeated into the commercial blood banks, of which we have 2 in the country. So we've got Sanbus, and then we've got Western Cape Blood Transfusion Service. Then, of course, Prof. Jacobs was a very keen collaborator with international colleagues, and he stimulated collaborative research with the Cambridge and Oxford team at that time, which defined the role of this thing called campath in the bag, or T-cell depletion, or ex vivo T-cell depletion in the bone marrow grafts. Now, just to give you like a wide overview of the history, so in 1974, the first bone marrow transplant was performed by Peter Jacobs. This was a sibling allo. Then in 1991, the first registry was created. This is the SABMR. That was by Professor Annette du Toit in collaboration with Prof. Peter Jacobs. And then in 1997, they performed the first matched unrelated donor. That was a Belgian donor. And then in 2002, the SASITS was founded. That's our Stem Cell Society. And then in 2015, the first transplant unit received JC accreditation. That's from my colleague, Dr. Jackie Thompson, and also Andrew MacDonald sitting here, and also David Britton. Not sure where he is, but he is here. And then, of course, in 2018, the second registry was founded by the Sunflower Fund, and in 2021, the Sunflower Fund was incorporated into the DKMS. Now, just to take a step backwards before we talk about CAMPATH, so Herman Waldman, which was affiliated to Oxford at the time, and Geoff Hale at Cambridge, they also produced CAMPATH in 1978. So immunologists at that time, they invented the technology to make monoclonal antibodies. And of course, graft-versus-host disease was a very important immunological disorder with a lot of complications post-transplant, and of course a good target for their research. And that's how it all started. So the big question was, can CAMPATH abrogate GvHD by eliminating the T cells in the bone marrow grafts? So T cells can be depleted by using an anti-CD52 antibody, that is CAMPATH, and it's directed against the CD52 antigen that's present on the B cells, the T cells, monocytes, and the dendritic cells. Firstly, they created a CAMPATH-M antibody, which was a murine antibody, and that was capable of dissolving the T cells in the bone marrow graft in combination with a complement. But there was a problem that there was a high rate of graft rejection, so it didn't eliminate the host T cells so much. So secondly, they created an IgG fraction, which then led to better in vivo, ex vivo depletion of the host cells and therefore better rejection rates. Thirdly, they humanized this antibody by genetic engineering, and then they created CAMPATH-H, which is the human formulation, and that was in 1988. So Herman Waldman then constituted this CAMPATH users group in the UK, of which Professor Peter Jacobs was a member, and this heme team at UCT started using the CAMPATH in the bag and formed part of this initial experience of its effect on transplant. So that's how it all started. But South Africa, then in the 70s, and even now, we have very unique challenges. So we currently face a very high burden of disease. We are faced with quadruple burden of disease, actually. So we've got communicable diseases like HIV and TB. We have non-communicable diseases like obesity, diabetes, cardiovascular disease, and cancer. We have a very high maternal, neonatal, and child morbidity and mortality rate, and even, unfortunately, high levels of violence and trauma. The non-communicable diseases account for about 40% of the total disease burden, and then TB and HIV account for 26% of all the deaths. This was in 2015, of which TB was the main cause of death. But we have continuing socioeconomic challenges and inequality. According to the World Bank, we are the most unequal country in the world, with a Gini index of about 63. Now, this was in 2021. What is the Gini index? So it measures the extent to which the distribution of income among households, and for that matter, individuals, within an economy deviates from a perfectly equal distribution. So a Gini index of 0 represents perfect equality, while an index of 100 shows perfect inequality. So based on this, we are the most unequal country in the world, sadly. Unemployment is around 32.5% at the end of 2020, and this obviously remains a key challenge in our country. And this has all been exacerbated by the COVID-19 pandemic, of which we had a 7% contraction of our economy in 2020. Then, of course, the healthcare sector is unfortunately not spared from inequality. So we have the double-tier system. So we have a private healthcare sector, but it only serves 16% of the population. So there you can access world-class therapies, but that's also a sometimes, because that depends on the medical aid and the tier of the medical aid. Secondly, the public sector is accessed by 84% of the population. So we have limited resources, and therefore most beneficial treatments are prioritized for the largest number of patients, kind of like a rationing. So coming back to Idrc in the 1970s, that was where the first allogeneic transplant happened. But graft-versus-host disease in our population will lead to poorer outcomes, obviously. And that's based on all the factors that I described above. But apart from that, if we think about the patients, some patients cannot actually afford the public transport or even the frequent clinic visits. It's quite costly. What about the poor living conditions, so hygiene and increasing fungal infection rates, compliance with immunosuppressive therapy, and of course, we have a very unique infections in our context, like tuberculosis, and then even the inundated public hospitals might limit needed supportive care, especially for GVHD patients. So Campath or alemtuzumab was this, or is this, the solution for our population? And my question still remains, was this Prof. Peter Jacobs' vision, idea, or hunch? I'm not sure, maybe. Now I'm shifting a bit of gears to the evidence base. So I'm going to discuss two papers, and that's about Campath actually being a little bit better than ATG. So this was in 2011. It was published by the group in Dana-Farber. And what they did was, this is the reduced intensity conditioning context. They looked at 1,676 patients, all with hematological cancers. They used fluci as the conditioning. This was in the match-related and matched-unrelated context. And clearly you could see that the alemtuzumab versus ATG versus unfractionated grafts had lower rates of acute and chronic GVHD, but a little bit higher incidence rate of relapse. The disease-free survival was a little bit lower, but the overall survival remained the same. And then they published and said that there's a cautionary note on the use of T-cell depletion. Then this was a UK-Spanish collaborative group. They showed that adding Campath, and this was now comparing not alemtuzumab with ATG, but more with methotrexate and CNIs, or cyclosporin. This was a non-randomized retrospective analysis in the context of lymphoproliferative disorders. It was only 129 patients. They used peripheral blood stem cells and reduced intensity conditioning with melphalan and fludarabine, and they had Campath patients, or they added 100 milligram Campath ex vivo with cyclosporin and compared it to patients that received methotrexate with cyclosporin, and they also allowed escalated doses of DLI. What they saw was that there's a higher GVHD rate on the methotrexate group, but a higher infection rate, especially CMV, and relapses in the Campath group. But then again, the overall survival was much similar. What about the pharmacokinetics of Campath? So here they compared in vivo with ex vivo. This was based on 10 stem cell transplants, and this was done by Geoff Hale. And they compared the in vivo and the ex vivo using Flumel and cyclosporin. And the two groups was where they gave 20 milligrams for 5 days through the vein, or in vivo, versus the ex vivo alemtuzumab, where they gave 20 milligrams in the bag. That's the myeloablative group. And what they showed was that the alemtuzumab concentrations in the reduced intensity group, so the in vivo group, remained at lympholytic levels for approximately 56 days post-transplant. That is 26 days longer versus the myeloablative group or the ex vivo group. The total lymphocyte count then significantly lowered in the reduced intensity group, persisting for more than six months after transplant. And the median absolute CD4 counts above 200 were delayed for 9 months after transplantation. So clearly you could see, yeah, if you used in vivo Campath, it affects your immune reconstitution and probably your graft versus leukemia effect. So ex vivo is definitely better. Then I found this amazing paper. This was published by Peter Jacobs and Lucille Wood. This is in 2009. And they looked at all the transplants at Idrc. That was about 320 patients, and they showed comparable results to established first world reference centers. In addition, they show that ex vivo T-cell depletion is the seminal observation that survival curves are stable and do not have late and unrecognized sequelae versus those generated in recipients exposed to conventional immunosuppressive regimes. They also concluded that there is no apparent impact of this unique immunosuppressive regime on developing myelodysplasia or predisposing to chronic infections like tuberculosis, especially in our context. And it remains to be determined whether the slightly higher incidence of CMV actually translates into any clinically significant important requirement other than proactive antiviral therapy. But now, Campath in the bag needed, and in my opinion, probably still needs, a little bit more refinement. So the questions remained, what is the optimal graft concentration to prevent UHD, what is the most ideal antibody dose to add to the graft, do you definitely need complement, and whether alemtuzumab is actually infused to the patient once it's bound up all the T cells, impacting immune reconstitution and even the graft versus leukemia effect. So the successor of Peter Jacobs was Nicholas Nowitzki. This was also at UCT. And what he showed here was, and they did a lot of research, or basic research on Campath, is that it does definitely reduce the CD4 and CD8 fractions, but it does not eliminate the NK cells nor have an effect on the stem cells or CD34 cells. What he did also show was that you definitely need serum or complement to activate the antibody and to eliminate the T cells. And then they were able to derive that the optimal cell killing in the graft without detectable free alemtuzumab in the supernatant could be achieved with 1 milligram antibody per 100 moles containing 10 times 10 to the power 9 mononuclear cells with complement. So that was the closest kind of like to the truth we got in terms of adding Campath, a specific concentration to the bag. And that's what Idrc till today actually uses. So just to summarize, these are the two different strategies we follow currently in South Africa, and I'm going to split it into two. One is public sector and one is private sector. So in the public sector, for the lymphoid malignancies, we use a TBI fludarabine-based conditioning. For match-related donors, we add no ATG. For the matched unrelateds, we add ATG 3 milligram per kilogram for 3 days, and then we add Campath to the bag. That's a calculated dose based on Nick Nowitzki's research. And then, of course, we use CNI from day -1. For the myeloid malignancies, we use Bumal-Flu. For the match-related, we do not add any ATG. And for the MUDs, we add ATG, and then again, the Campath in the bag. In the private sector, it's a bit different. So the conditioning is much the same, but the ATG that we add is a little bit lower in concentration, 1.5 milligram per kilogram for 4 days. So the cumulative dose is a bit lower. And the Campath we use is a little bit higher. So we do match-related donors, we add 8 milligrams Campath to the bag, and for the matched unrelated, 12 milligram to the bag. So then I shift gears altogether to what about haplotransplants in Southern Africa? So, I mean, this is imperative. I mean, as South Africa, bone marrow registries are not representative of our local population. So we, in 2017, had about 73,000 donors available, but all of Caucasian origin. So secondly, we have a very ethnically diverse population. South Africa has the highest seroprevalence of HIV in the world, about 13.1%. And this obviously restricts our donor pool. And then matched unrelated donor transplants, especially international donors, can be prohibitively expensive, even with patients on a medical aid or with medical insurance. And then, of course, this is an important transplant, especially in time-sensitive hematological malignancies where you need a transplant quickly. So then, eventually, we published this paper. We are very proud of this paper. And it's based on really collaboration with Idrc Hospital, and thank you to Estelle for always pushing me to do this. And it was a mixture of myeloablative and reduced intensity conditioning. It was about 74% myeloablative and using the PTCY method. It's a retrospective analysis of about 134 patients with hematological malignancies and then using an unmanipulated haplograft with PTCY, and that was at Idrc Hospital in Pretoria East. This is the first study published where there's a collaboration between public and private transplant centers. And we obviously assessed all the conventional outcomes. So the overall survival per disease type, so we could see the 1-year overall survival for AML-MDS was about 55%, for the ALL group 41%, and for the other group 65%. The other group consisted of lymphomas and some myeloid malignancies, chronic myeloid malignancies. And then disease-free survival at 1 year, we could show that was about 54% at 1 year, for the ALL group 32% and 46% for the other group. Looking at acute GVHD rates, unfortunately, this is not a cumulative incidence because we did not have the date of diagnosis of the GVHD, so we could not, unfortunately, calculate that. But most of these patients did not develop acute GVHD, 58%, and if they did, it was grade 1 and 2 predominantly. Looking at the cumulative incidence of non-relapse mortality, so at 100 days it was 18%, at 1 year it was 35%, and at 3 years it was 41%. 69% were all transplant related. If we looked at the cumulative incidence of relapse, at 100 days it was 16%, at 1 year 19%, and at 3 years 21%. When we did the regression analysis on the univariate, older recipient age was a risk factor for non-relapse mortality. Not really a surprise. And then on multivariate regression, we could show that if you had an older donor, you had inferior disease-free survival. If you had an other diagnosis, you had a higher relapse incidence. And if you used peripheral blood stem cells as a graft, also a lower relapse incidence. And finally, if you used an offspring donor, you also had a lower relapse incidence. So the discussion was that AML-MDS subgroup, the overall survival approximates that of other reference centers, but the LL group seems inferior versus other publications. We're not exactly sure why. It might well be that our MRD assessment is a bit different in this country. It's not really standardized. It can also be that we use different induction regimes that are quite intensive, so we're not 100% sure, and that needs further study. But on the multivariate regression analysis, older donor age was significantly associated with inferior disease-free survival. There is conflicting evidence on this topic. We had a lower relapse incidence with offspring donors. There has been similar observations by Solomon and McCurdy. And then, of course, lower relapse incidence with the use of peripheral blood stem cells versus 2 meta-analyses that show a higher acute GVHD rate, but no impact on overall survival or relapse incidence. Our 100-day non-relapse mortality was on par, but the 3-year non-relapse mortality rate was inferior to other publications. And then on the univariate, the older donor recipient age was a risk factor. I think that's a conventional risk factor for inferior non-relapse mortality. And then unfortunately, we also had a high rate of graft failure or dysfunction at 17.2%. It might well be that, that our donor-specific antibodies might be playing a role here, and it also might well be that our population, that we're testing the wrong antigens because we have a very ethnically diverse population. So that's still research that needs to be done on that topic. The advantage of this study was that we could show a collaboration between the private and public sectors, which was great. And we hope to stimulate ongoing research and collaboration. This data does serve now as a comparator to improve the outcomes and quality of healthcare to our patients. And haplotransplant is a valid option for patients with high-risk hematological cancers in South Africa as compared to matched unrelated donor transplantation. It is consistent with the imperative to provide affordable and equitable access to stem cell transplant for all patients in South Africa, irrespective of your socioeconomic status. But we're currently facing a different challenge now, and that is to access the CAMPATH. So CAMPATH has always been accessed via a compassionate use program, via Sanofi Genzyme, and when we use medicines like CAMPATH that's not registered in South Africa, you have to do a Section 21 application through our regulator called SAPRA. Unfortunately, Lemtrada has been registered in March, April this year, and therefore we cannot actually get this on compassionate grounds anymore. So the concern currently is that this will limit access of transplant even more in the public sector. The Lemtrada, I asked Andrew this morning about the price of the Lemtrada. It's about 116,000 Rand just for 12 milligrams. That is definitely not feasible in our public sector. So the question still remains now, is PTCY maybe the solution for South Africa? So Bronwyn touched on this paper about Bolinas Mead, published in the NEJM. It was in the reduced intensity conditioning context. It was a phase 3 RCT, very well done. It was for match-related donors, matched, unrelated, and mismatched. And they compared the PTCY with tacrolimus and MMF versus just tacrolimus and methotrexate. And they showed a superior adjusted graft versus host-free, relapse-free survival in the PTCY group, as well as lower rates of acute and chronic GVHD. And then, of course, the adjusted disease-free survival and overall survival was superior. So they concluded that among patients undergoing an allo-HLA-matched transplant with reduced intensity conditioning, GVHD-free and relapse-free survival at 1 year was significantly more common among the PTCY group. So, and keeping the public sector in mind, I think cyclophosphamide is easily accessible and quite cheap, and this might be the solution for South African public patients and even some private patients. Thank you very much, and I don't know if there are any questions, and yeah, I'll go and sit there and then we have a discussion.
While we're waiting for microphones, Dr. Andrew McDonald, he is the transplant director of the biggest transplant center in sub-Saharan Africa. And Andrew, you are the quintessential transplanter. So we're thankful to have you here. So, there's the... So you can sit down. I would have made you stand here, Andrew. But now we're getting a microphone.
Share it.
So, I think what stood out from the session was best donor and best GVHD prophylaxis for me. Let's see what... These lights are always very bad. So I think for us to see better, we must dim them if possible. So please just perhaps rise from your seat and make yourself known, and then you can also receive a microphone, I hope. So are there any questions for Bronwyn, for Andrew, for Justin? Stephen. So.
I'll kick it off. I don't know if I can talk loud enough. It's actually for Steve Devine, NMDP. This is for you, Justin. Just a little bit more about the graft failure. 17% is pretty high. Obviously, haplos are associated with more graft failure. Could you tell us a little bit more about the donor-specific antibody issues in those recipients, how you handle that? Do you do attempts at desensitization, or just do you keep looking for other haplo, even cousins and so forth? Because again, that looks like a big problem. One of the things where we see the mismatched unrelated donor issue is we can usually find a donor for people who are highly alloimmunized, because we have so many potential mismatched unrelated donors. We can find a donor that the recipient may not have antibodies directed against, the mismatched HLA. And the other thing is, does this affect your patients who have prior pregnancies, multiple pregnancies previously, higher incidence of DSA, and are you not able to transplant some of those patients with even haplodonors because of this issue with antibodies? Just sort of a gender equity question as well.
Dr. Devine, thank you for that very long question and very important question. So in this study that we did not focus, unfortunately, to collect the data on the donor-specific antibodies, although it's a very important issue. What we do know is that we do test now for donor-specific antibodies. My concern is that when we do those testing, that we're missing certain antigens in the test, and we might not pick up certain antibodies. That's quite significant. So I would like to do a study soon to look at the antigens that we test for versus our haplofrequencies. So that will be one study that will soon come, because I think that's an important issue to address. In terms of desensitization, yes, we do, and we follow the MD Anderson protocol. So we do the bortezomib, followed by plasma exchange, alternate days, then polygam, 1 gram per kilogram, or IVIG, and then initially we did a Buffy coat as well, but we've abandoned the Buffy coat now. And I must say, I don't know what Andrew thinks, but I think the desensitization protocol works really well. The patients do engraft, and they do fine. Andrew, do you want to make a comment?
Yeah, just a story about the DSAs. I mean, we definitely need a study, but I've got some data just to show tomorrow in my talk that we are missing the commercially available lab panels don't have all of our represented antigens in the mix. So that is actually a big issue when you think someone hasn't got DSAs, but actually they potentially do. And what to do with those patients is really an open question. Just in terms of a lot of those patients actually came from our center, so I think that was really the early days for us. I think the big advance has been decreasing the dose of PT-Psi, which we've now also done, and we're certainly seeing a lot less BK hemorrhagic cystitis, I think a lot less graft dysfunction, and better outcomes. So I think that's certainly been a game changer for us. And in terms of the early days, in terms of desensitization as well, we weren't quite as on top of doing that sort of whole full program, but which we are now actually doing. So I think if we had to repeat that study, we'll definitely have better outcomes. That data, I think, was censored in 2018 or 2019. So it was sort of like the early days for us. The other thing we also changed was up until 2015, our center did primarily bone marrow harvests for haploidentical transplants, but we sort of constraints in terms of resources, etc. We've swapped almost invariably to peripheral blood, except in non-malignant diseases.
Yeah, that's interesting. I was going to follow up with another question, but in the US, I think people initially started getting quite interested in these desensitization protocols and sort of have moved away from them. I think largely because there are other options like the mismatch unrelated donor, and it's similar with older age, where people are more willing to go to a different donor when you've got these kind of complications that might take time. And so I just wanted to follow up, Justin, because you said that you desensitized and it was generally successful, but you still had that 17%. So was it still associated with people who'd had a desensitization? And I was interested because you also said graft failure or poor graft function. And we really struggle to define that, to really be able to characterize poor graft function. So what was your criteria? Did you have a very specific criteria for that?
Yeah, so we use the EBMT definitions, but I must just say that, as Andrew said, this was in the beginning, this study. So the desensitization and the ideas of it only came afterwards. So you see what I'm saying? So I think for now, the desensitization and our experience now is getting better with the desensitization. Yeah.
Great, thank you.
Although it would have been nice to report that in that same study, but we didn't have the data.
I agree with what Andrew says. It was the very first results. We started from the very first patient. And we also did not really know what we know now. We found it out in our results that we shouldn't use older donors. So if I think of the 2 patients we desensitized, whether it was during the period or after, I can't remember, they were older mothers. So I think that makes a difference. So these results were not always what we wanted, but I definitely think that they can be improved upon. And part of this conference is going to be to see how our donor unrelated donor situation is improving in Africa, which is just as hopeful. I don't know, please, Pierre. Yeah.
Hi, thank you very much for good sessions. My name is Rachel Pawson from the British Bone Marrow Registry and the NHS Cord Bank in England. You told us about the very high seroprevalence rate of HIV, so I'd be interested to know if any of your transplant cohort included patients with HIV, and if so, what do you do differently, and do you select different donors or try to for HIV positive patients? Thank you.
Difficult question. Andrew, do you want to answer that one?
So yes, they did include HIV positive recipients. I don't think that the outcomes are terribly much different. I mean, if they're controlled, by the time you're getting to a transplant, we really have controlled the HIV. You might be left with some, obviously, residual immunosuppression and T-cell exhaustion, but I don't think we haven't had a lot of HIV recipients, but I mean there is a number in that cohort, and also in the matched sibling donors as well, and the matched sibs as well. We've only done one HIV positive, used one HIV positive donor. It was for both siblings were HIV positive, controlled, and the sister had aplastic anemia, and there was really no other donor for this patient, so we did use the HIV positive donor, but this was a heavily pre-treated aplastic, and he actually had primary graft failure, and then didn't make it to the second transplant, salvage transplant. So I mean that's really an open question in terms of using HIV positive donors. I think there's going to be some discussion later in the conference about that, but how do we incorporate that into a protocol looking for donors?
And the conversation about HIV positive patients is very interesting, because certainly in years gone by, HIV positive was always an exclusion criteria on clinical trials. I don't know if you still see it here, that's because obviously you're making decisions to pick the patient or not. And we specifically opened that 15-MUD study to HIV positive patients because of the possibility of finding a donor with a CCR5 polymorphism. And in fact, we had 5 patients transplanted on that study. Well-controlled HIV, of course, because these are people who've been able to have drugs. And they were transplanted for a hematological malignancy. So, they had a lymphoma or whatever it was. But for each one of them, we were able to find a donor who had the polymorphism, because you weren't worried about HLA. And so that's another benefit of being able to use this HLA mismatch setting, like avoiding the antibody DSA thing, is also being able to look at other polymorphisms or other genetic factors that might coexist in a family setting or might, be otherwise beneficial.
Just a comment about the CCR5. I mean, obviously, that's predominantly a white population, and then for our patients where most of the HIV is actually found in the black population, just the likelihood of finding a donor is quite remote. So we haven't specifically actually had that experience where we've been able to sort of select a donor based on that mutation.
I'll just also make a comment. So at our center, we do mostly autologous transplants for HIV positive recipients. We've hardly done any HIV positive allogeneic transplants for a recipient. Conversely, we've never used a HIV positive donor because just about its uncertainty. Not only that, I think Candice Hendricks, who's a colleague of mine, she's a pediatric hematologist. She's busy doing a PhD now at the University of Pretoria, looking at cord blood where HIV exposed infants with ARVs on board have an effect on the stem cells, the cord blood stem cells. And that result was actually fairly promising. That is available now. But yeah, it's an interesting topic for South Africa and in our context.
Yeah, Pierre?
I am Pierre. I am the chair of the Belgian Central Register. But I have a general comment. We are looking to donor data, to also data for treatment with some blindfolding. Sometimes, I'm already retired 6 years and I'm not active transplanter anymore, but sometimes I meet some patients in the train or in a warehouse and they say, "You have saved my life." And I say, "Oh, yeah, happy." Sometimes I remember these patients, often I don't remember them, and I ask them the question, "How many years are you transplanted?" And they say me, "Yes, 20 years. What I mean is that we are looking to data short time, and we are lacking a lot of data what happens after 10 years, 15 years with our patients. This is a general comment from me.
I think that's a very important comment to make, because along with studying things in clinical trials instead of just looking at practice in individual centers, and using the registries, that's where we have the value of very long-term follow-up, of looking at patients who've had very different approaches to transplant. I mean, we have in the CIBMTR now, you know, it's been going for more than 50 years. So the registry, just like the EBMT, has got patients who 25 years survivors and 30-year survivors. You can look at subsequent neoplasms, you can look at the other sort of organ outcomes, but you're really looking at those patients that were transplanted in the way we transplanted people 25 years ago. So your point is very well taken, that we should make sure that we are, I guess, measured in what we consider the outcomes when we're talking either a year, but even 3 years or 5 years with newer approaches. Completely agree with you.
Thank you very much. I'm Sergio Querol from Spain, from Redmo. I want to ask Bronwyn about the HLA weight in all of this, and your suggestion that going down in HLA match can help maybe even countries with small registers, because the mismatch can be confronted by PTCI mainly. So you have data on not only the single mismatch, you said less than 7 out of 8. So the concept of the Apollo mismatch unrated donors, or let's say for patients that we don't find donors, using these very low matched donors is resulting in decent outcomes.
Yeah, thanks, Sergio. So, you know, in the 2 studies that we've done, the mismatch MUD and the access study, we can see that people picked a donor less than 7 out of 8. And so we know that that's needed, because many of the transplant centers actually went for a 7 out of 8 first. And so going less than that was often the situation that they didn't have another donor. And that's about a third of the transplants that are occurring. You'll also see some data tomorrow from just showing the NMDP operational data that we are seeing increases in the number of donors matched less than 7 out of 8. We also know that in some centers, people are actually picking other characteristics. So in my center, for example, even if there's a 7 out of 8 matched donor with PT size setting, we'll often choose a younger donor who's 6 out of 8 or 5 out of 8 because we believe that that age in that particular circumstance was more important. But all that to say that these are very low numbers currently. If you look at the clinical trial outcome, we haven't seen significant differences in those two groups. Of course, once you get down to the 4 out of 8 and 5 out of 8, you're talking about numbers, that are really low. But if you look at the 6 out of 8, there's no appreciable difference. It's also probably, though, that there's some sort of selection bias going on too. Maybe it's people who are more experienced at this or are picking other donor characteristics. So it's very difficult to say right now that we've got strong evidence. But I would say that all the evidence we currently do have suggests that, that in the mismatch unrelated donor setting, this is an acceptable approach to take. I will say in the haplo setting, there's been, there are many, many more patients available for analysis already. And we've definitely seen data showing, in fact, that more mismatches might be associated with better outcomes than fewer mismatches. And we're seeing, for example, DRB1 mismatches associated with favorable outcomes, or that DP non-permissive mismatch, as I showed you. So we're getting more information from the haplo setting. We'll obviously continue to study that in the mismatch unrelated donor setting. But personally, especially if it's on a clinical trial, I don't think that people should overly worry about it. But in terms of standard of care, what we're mostly seeing is people picking a 7 out of 8 rather than more mismatched.
Good morning, it's Daniele from Brazil, the Brazilian Registry. And Bronnie, I would like to ask you about the last algorithm you showed us, considering the HLA match probability, and then we go from one arm to other unrelated donors. But at that algorithm, you didn't include the age. I think that you discussed it only considering the match probability. If you have the probability of having a match donor, and then you go. If you don't, you can try an unrelated donor, mismatched donor. But how would you include the age at that algorithm? Because many times that's the final question. You have like an older match related donor, and then a younger. Because I think that's one point. And the second point is about how to transport or to translate directly what we can see in the standard of care in US to other countries. We have seen here the reality in South Africa. I'm from Brazil. And there, we also have some data very interesting that when we exclude, for instance, the cost of the product, so when we compare that unrelated donor with a related donor, and both have no cost for the patient, we can see that, for instance, the haplo has a higher cost for the patient and for the hospital, especially because of complications that we have, like infections. Because you discuss access to a matched donor. It's a fact. It's also a problem in Brazil. But in Brazil, we still have some access problems, including, for instance, the best treatment for CMV and other viruses, and some medicines for GVHD control. So that's what I would like to ask you both.
Yeah, thanks, Danny. Lots to unpack in that one as well. In that clinical trial, it wasn't randomized, so people followed the algorithm with the search prognosis, but because it wasn't randomized, there was a small proportion of patients who didn't do the thing that they were supposed to do. So if you were very likely to find a matched unrelated donor, over 90% of the people on that arm did get transplanted with a matched unrelated donor, but about 10% didn't. And so it's possible that people would have made a decision based on some other factor that might have been very important to them, you know, which I guess donor age could have been one of them, although often these donors that are going down that route of highly likely to find, very likely to find a matched unrelated, tend to have a lot of different options. So it doesn't usually end up being a problem. In terms of the mismatched unrelated donor, you know, the NMDP's done a lot of modeling. You've seen it showing that even if you restrict the donors to under 35, you can still always find a donor for the patient if you go down to 6 out of 8, 5 out of 8, irrespective of their background. And I think in practice in the US, that is one of the reasons why some of the people who were doing haplotransplants by preference before now have moved across to a mismatched unrelated donor because of the age issue. It's interesting, when we started that clinical trial, the transplant centers told us for the alternate, for the people who were very unlikely to find a matched unrelated, that they would, 70% would get a haplo, 15% would have a cord, and 15% would have a mismatched unrelated. But if you look across the study, that mismatch went from that, you know, what people predicted, actually up to 30% actually used, and haplo was less, and the cord bloods were very much less. So people's practice changed even over the time of the study. So I think we're learning things as we go along and having to change our practice as we try and answer some of these questions. Justin?
Yeah, I have a question for Andrew and for Estelle. Unless there was another question, I wasn't sure.
We've got one in the middle. Hi, it's Robert Denby from Anti-Nolan. Thanks for a wonderful session from the panel. In the middle, right at the centre, hi. Question for Bronwyn, I guess. You've shown really nice data about the interaction between age and HLA and this question about siblings versus unrelated donors. So perhaps a slightly rhetorical question, but how old is too old now for HLA-matched sibling or a haploidentical donor?
Yeah, it's a great question. I don't know the answer. Most of the studies that we've done through the CIBMTR or other in the registry have been, I think EBMT's followed something similar, where you've tried to have a patient over the age of 50, because the problem is that obviously your HLA identical sibling and your patient's age are going to be very similar, and so you have to select the age of the population that you're going to study in a way that you can really get to the answer. But we struggle with that on a daily basis in our transplant centers, right? So, if numbers are so artificial, is a 59-year-old sibling going to be better than a 60-year-old sibling, And so I don't think we know that answer. I suppose the only way we would answer it is in a clinical trial, but you'd have to have so many patients to get to that age question that I think it would be hard. So pragmatically, I think for siblings, many transplant centers say 60. For haplo, some transplant centers are saying 50 for the donor age. But I don't think there's a standard, and if anybody else has a standard that they use, that would be interesting to hear.
So I know the registries in South Africa, so my feeling is that they're doing a lot of work on getting donors. And these days we see, even for our non-Caucasian patients, that we would have a 8 or 9 out of 10 match. So my question to Andrew and Estelle is, would you do a mismatched unrelated donor transplant above a haplotransplant these days?
I think I asked Andrew that question.
Yes, our haplo numbers are going down as well. At our centre, and our number of unrelated is increasing. So I think the answer is yes, we are.
So we haven't done it. We are a public transplant centre, and we have really restricted resources also regarding nursing doctors. So I really love this algorithm. I think it does open your mind to think differently, which may not sound so important, but it actually is, that you actually start thinking differently. And thanks to the donor organizations and the WMDA in South Africa, we are now, the other day I had a mixed race patient with 27 matches. I said to my colleague, that's not true. I said, that's just nonsense. So and this patient happened to have an Asian, you've got these codes, you would know. He had some kind of Asian grouping in the WMDA. So I think we must actually send this question back to Justin, because you've seen that we are also restricted in our ability to do research, but we are trying to change that. And I do think that this is the type of question we should answer in South Africa in a prospective sort of best care study, which doesn't take forever to be approved in our country with lots of restrictions, to actually test this. And my question to my two private care colleagues in South Africa would be, and also to other countries like Danny from Brazil and these places, would such an algorithm do you already implement it? Is it just already happening? Or would the acceptance of such an algorithm, this search algorithm, would it actually change the way you would be able to get funding for your transplants? That's just my question. And also if there's anybody else in the world that has thought about that.
That's a difficult question. But you know what I think? I think that if you have good studies done and you have an algorithm based on some data, choosing the best donor in South Africa, the medical funders would probably fund the transplants easier. So I think that's definitely something we should do, and we should definitely stimulate more collaboration with the international registries as well. I'm just thinking now in terms of PTCY. I've got a question for Bronwyn. In South Africa, if you had a choice, and I mean this is now Campath in the bag versus PTCY, it's probably a difficult question, but what is your hunch? What would you think you should do? I mean, how would we convince the senior transplanters to change our point of view, to change our GVHD prophylaxis?
It is a hard question, but because, as you know, I actually did all my training in the UK, and so a lot of the transplants, I mean, the majority were done using Campath, and I totally understand that thought process of avoiding GVHD, of doing everything you can, you know, that is your goal, not to give a side effect from the transplant. Because I'm thinking about those years in the UK, right at the beginning, there was Campath in the bag, and it didn't go well. There was a lot of relapse. I mean, there were a lot of CML transplants back then, you know, so salvageable patients with DLI coming along, etc. But, you know, in the UK, Campath in the bag went away quite quickly because of that increased relapse. Campath in vivo, there were lots of different approaches. You know, obviously, like you said, there was 1M, 1G, 1H, you know, we moved across the time. There were Campath de-escalation studies, which is really interesting because you probably could have predicted that PTCY, you were going to have some de-escalation studies based on some of this other practice. And, you know, the outcomes definitely were better with infections once you de-escalated. We were giving way too much Campath in the UK early on. And then we were doing some things like giving the 1H like 22 days before the transplant. I know you've had some of those approaches where you're doing that. I would say from a practical point of view, just like you mentioned, Justin, it became really hard to get the Campath. You know, Campath now people have for MS, so suddenly it's worth some money to somebody, and transplants small potatoes, right? So nobody wants to fund it. I mean, I remember when I was a junior transplant doc, we used to go down to the blood bank and get the little frozen vial of Campath out the fridge and hold it in our hand and defrost it on the way up to the floor to do the transplant. You know, that kind of stuff doesn't really go anymore. And as was mentioned, and you said it, PT-Sci it's available, it's cheap, people understand how to use it. So from a practical point of view, and especially in resource-constrained countries, and it makes a lot of sense. So, you know, I think if you want the answer for South Africa, PT-Sci might be something that is ultimately easier for you to use, but it probably isn't the only answer or even the best ultimately. And I think Estelle's exactly right, that you have to do some research, and because you are a smaller community of transplanters, you could maybe do some really innovative stuff that other people can't do because they're bigger, that you could really understand some important outcomes using the PT-Sci.
Thank you. Actually, I just want to ask, would you think a propensity score matching study comparing our data, so let's say proper collected data through CIBMTR or EBMT registry data, because we have the 2 JC accredited units now, and doing a propensity score matching with our method, with the PTCY method, that might be a way to
Yeah, I think that's a
change the
really
people's
interesting
minds.
question.
Okay.
I like that. And, you know, I mean, there are a few prospective clinical trials now looking at the ATG versus PT-Sci question. And, you know, what happened in the UK is just an exactly a bad outcome of this Campath story availability, because obviously the standard of care is Campath, but they couldn't compare Campath to PT-Sci because the company wouldn't allow them, and so the regulators wouldn't let that be the control arm, and so now it's ATG versus PT-Sci, which is fine, except that's not your standard of care, so it's hard to compare. So I think using these other sort of more novel statistical techniques, or borrowing from clinical trials, or using registry controls is probably the way to do some of this.
I'm Kalinga Pereira from Wishbone Maradone Registry. Thank you very much for enlightening talks and the discussion. My question really is, you might remember in November in Minneapolis, we had a really big excitement about when we discussed the test results and then the trial results about the mismatch transplant with the PT-Sci. And the idea is that anyone who previously haven't had the availability of the donors can have the donors which are mismatched, and also with the PT-Sci they will be having the opportunities. Now that we see the haplo is taking that space more rather than the donors with lesser matches, do you think it is the case, or is it this PT-Sci mismatch transplants just taking this haplo space?
I think I'm understanding your question about the change in practice with haplo and mismatch. I mean, I think we've seen that in the CIBMTR data, the EBMT data that was recently published from their survey report. And then what you just said is that haplos are going down across the board. And I'm sure that there's multiple reasons for that. PT-Sci is obviously a platform now that's being used much more broadly than just haplo, but this donor age issue we've discussed, the donor-specific antibodies is a real key thing, and then, other novel strategies or medications coming along. So I don't know if I fully understood, but I think that in general we're seeing haplos going down.
Good morning, dear colleagues. My name is Nara Stepania, and I'm a head of collection stem cells department of Russian Cancer Center. We're one of the biggest pediatric center, and when we discuss about the haploidentical transplantation for the population of the children, not so often we can find unrelated or unrelated donor. It's a problem for us, not only not only in Russian registry systems, but in the whole world. Or we have the other problem, it's the logistics and the very fast to providing us with the stem cells from other countries, because we unfortunately haven't got the straight flights from the Europe, and it's this problem. And the one way of the solving this problem is using haploidentical donors for these children, may probably with including all the different sizes of T-cell alpha beta depletions. And my question is how we can use the unrelated donors more often for increasing of the using these types of donors for our children. Is it possible to do?
I think I understood that you said how would you increase using the mismatched unrelated donors?
Yes, sure.
Yeah.
Yes, sure, because when we use mismatched unrelated donors, we have a very big problems with acute graft-versus disease, and sometimes we see that we not achieve the engraftment of transplant after transplantation. This is a very big problem because we're going for the second transplantation.
So, as you've heard, we have not attempted it, and it's not because we are against it. We simply have been having our hands full with the haplo and more mud transplants. But I think the one person who could answer you would actually be Andrew, because they are doing the mismatched, so would be him.
Yeah, well, we're not doing pediatrics. That's the quick answer. But I mean, I get your problems. I mean, transport is also going to be a big issue to getting cells into Russia, I imagine. Yeah, I think in the end, you use what you can get. I mean, we can have policies and attempts to improve matters, and we can discuss that tomorrow again as well. But just practically, whatever you can get your hands on is actually what you can do. I mean, that's the bottom line for us as well. We're also constrained by resources and predominantly for us funding. And I'll show an example tomorrow, but I mean, the costs of cells from various registries varies enormously. And, just what you can get is obviously the best. I don't think that's really answering your question, but...
So I just wanted to make a comment. So we at our center, so we've only done about 15 allogeneic transplants in pediatrics last year. What is happening in South Africa is very fragmented in terms of pediatric transplant, but it's nowhere near where we should be doing allogeneic transplants in the pediatric setting. So we've got Candice Hendricks, as I mentioned before. She's a pediatric hematologist. She's coming back from Italy in Monza, where she will join Andrew and them to create a specific pediatric allogeneic transplant. And the plan for the country is hopefully to take the public patients and transplant them in the private sector, because we think there's an issue with access in terms of getting to transplant, especially for the children. So that's a difficult question for us to answer, but what I can tell you is that we've only done matched related and matched unrelated. We have not ventured into mismatched unrelated or haplo yet, because our center is still very fresh.
I just wanted to follow up on the question about haplo versus mismatched unrelated donors, because I think that the decrease in the haplos in the U.S. is actually more nuanced. So if you look, it's almost all in the adult recipients. If you look at the CIBMTR data in pediatrics, there's no decline. Actually, there's a slight increase in the number of annual haplos, and I think it's because of alpha-beta T-cell depletion. In the U.S., most of them are actually using peripheral blood grafts from the haplo donors, and they have very good results with alpha-beta T-cell depletion. So Bronwyn mentioned that we actually have an arm on the access study which is still open. We've had great accrual on the adult strata, and it closed fast, but we have only accrued about 20 pediatric recipients because most of the U.S. centers are still doing haplos in the kids. And what we did, we actually looked at the DSA, or the HLA-directed antibodies, in the children who went on the access study, and almost all of them, which is unusual in children, were alloimmunized. So I think they were probably doing MMUDs in people who they couldn't find a haplo-related donor, and I think that's kind of what's happening. So I think there's going to be a big difference in the shift in adult versus pediatric. It's going to be a lot slower in the peds, and it's probably going to be for these people. It probably will be just an option for people who don't have the haplo option in the pediatric setting.
With that, and we've asked lots of questions. I'd like to thank our panel and our speakers for participating in the panel. I think it's been a very lively debate. It's opened some areas for everybody at the start of this conference. But you would have time now to go and network during tea time. But if you could please be back here promptly at 11. So enjoy the tea, and we'll see you soon again.